Hey everybody, welcome. Happy Pride Month. It's good to see so many familiar faces again and some new people. Welcome.
Cool.
All right, so as people are still coming into the waiting room and getting settled, I'm just going to go over a little bit of expectations for this group and what to expect. So I'm Ellie Jabul. I'm a therapist at Holistic Child and Family in Seattle, which is the company that hosts this consult. My pronouns are she, they. In this consult, we hold a commitment to listening to one another. What's said in this group is considered privileged information, and we're all responsible for helping maintain confidentiality for one another. In this group, we address many intersections of neurodiversity, including sexual identity, gender identity, racism, classism, ableism, and capitalism. We hold the understanding that we all live within these systems and we're all constantly in our own processes of unlearning and relearning. And so we want to hold this as a space where we can call one another in. We don't have to shame spiral or be defensive. We're all learning and bringing our own lens to this, and we can benefit from one another. So today we have Jana here to present to us. We have the first 45 minutes with that. I'm going to let Jana introduce themselves, and then we'll move into our consult space. As far as I know, nobody has requested to hold a consult space today, so just keep in mind if you might want to jump in with one of your clients, just be thinking about that. All right, I'll turn it over.
Hi, everybody. I'm Jana Cuneo. I use they and she pronouns. I'm a nurse practitioner in Seattle, Washington. I do primary care and I serve specifically the queer community, but all folks. So I'm trained as a family nurse practitioner. I practice more internal medicine, and I have a specific focus on gender diversity and HIV care as well. And my talk today is about creating a collaborative alliance between mental health care providers and primary care providers, specifically around the improvement of the experience in healthcare for our neurodiverse clients. I know y'all tend to call people clients. In medicine, we tend to call them patients. If my medicalized language is offensive, I apologize. That's just what I'm kind of defaulting to, but I'm going to try to work on that. And so a lot of what I want to talk about is sort of presenting from the primary care perspective. What are some of the challenges inherent in our model that are hard to work around, but also what are some of the things that y'all can do with clients to set them up for success prior to their first healthcare appointment, if that's something that causes a lot of stress and anxiety. And another thing I wanted to discuss is ways, like questions that clients can ask and things that we can advocate for them to ask so that they can pick out the right healthcare setting, because there's actually more of a variety available to folks than I think that they're aware of. And these are questions that can help steer them towards like the right environment for them. There's always an inherent issue with healthcare, which is both access, depending on which part of the country or the world you're living in, and insurance. And I'm going to acknowledge right up front that we have a very broken system. And, you know, the more challenged your client may be, the less likely they are to have an insurance that allows for a lot of choice and flexibility. And that's going to be a barrier in and of itself. So some of the options that I present to you might not be affordable to all clients, but I'll try to call those out so that you're aware. So I think I can start with the slides now. All right. So this is our partnering slide. Next slide. All right.
I'm trying to figure out how to place.
Yeah, I'm just going to let you figure that out for a second.
What am I missing? Where is play slideshow.
It's on this slideshow. It's on the right of animation. There's draw, design, transition.
Thank you, Marissa. There we go. Cool.
Okay, here we go. So next slide. Okay, nope, we went too far. Nope. We'll go back one more. There we go. Okay. Here we are. All right. So these are things that we are all pretty aware of, but just to say them again, the things that are hard for our neurodiverse clients in healthcare spaces. One of the biggest ones that I hear from my own clients is that they're in traditional medical spaces, there's strict penalties for late arrivals and late cancellations. And the definition of a late cancellation can really vary depending on the healthcare system that you're in. So some places will consider even 48 hours or less to be a late cancellation of a time, which you'll get penalized for, even if you did call 48 hours in advance. And some places will determine it to be a late cancellation if you call less than 2 hours in advance of the appointment. So getting clarification on that is really important. I have worked in healthcare facilities where if you have more than 2 ever late cancellations or late arrivals, then you get put on a list of people who are not allowed to schedule their appointments. They can only show up as walk-ins and wait in the clinic until a walk-in becomes available because they're not trustworthy enough to schedule, which is really uncool for so many reasons. And that happens to people, and then they feel penalized for something they don't always have control over, like if the access bus didn't drop them off on time, or their HopeLink ride didn't come, or they made it off the bus but then they had a panic attack and it took them an extra 10 minutes to get through the front door, and then they're late, and then they get denied their visit even though they got on the bus and they're on a list now that says they can't schedule. Like, that's a catastrophic event for a lot of clients and has happened to many. Lack of direct access to clinicians. So the bigger the system, the less they want us as providers to interact directly with our patients. A lot of times what happens is they set it up so that you have to send a message through 2 to 4 different humans who triage the message to see if it's something that I should even be looking at. And once they determine that it's actually a question for me, then I get to see it. But that could be 3 days after the message was initially sent, or I might never see it at all. And then a patient gets a reply that's unsatisfactory, and then they come in and they're like, I can't believe you did this to me. And I'm like, I don't even remember that you messaged, because it never came to me in the first place. Loud and distracting environments is a really tough one. So that's more like ER, urgent care kind of scenario, where there's a lot of people moving in and out, beeping sounds, that kind of thing, or other children, and chaos inherent in that. So that's, if the waiting room is already that loud or that chaotic, that's enough to send people hiding for the rest of the day, let alone get through the actual appointment. We frequently in healthcare have like a clipboard with minimum 5 to 6 pieces of paper on it that we expect people to read and sign in 15 minutes or less. And then we yank it out of your hands in order to start the visit, and you haven't had time to actually read it over, but we expect you to sign it anyway, which is not legal. As somebody who's dyslexic myself, I can tell you it's really frustrating when somebody shoves you a ream full of paper and tells you it doesn't give you time to read it. That's really frustrating. Short time limited interactions. So the average visit length for a primary care provider in the United States is 15 minutes. And that 15 minutes is not 15 contact minutes between the provider and the patient. That's 15 minutes, including the vital signs, and reviewing all of the medications on the medication list. So in an average primary care visit, by the time I enter the room, I have 7 minutes for a patient visit. And that's a standard visit length. If somebody needs an interpreter, like an ASL interpreter, for example, or they need to ask any questions or repeat the care plan, then I don't get extended time for the visit, even though I have to say everything twice. So that's a real challenge. We empower people in healthcare to physically interact with patients all the time, and the minimum number of people that might physically interact with a client when they enter a healthcare space is 2 to 3, sometimes more like 4. So you come in, MA walks over to you, immediately wraps something on your arm and starts inflating it, and then a provider comes in and says, I hear about your knee, and then walks over and grabs your knee, and then you get done with the visit and somebody wants to draw your blood, and then they immediately start touching you again for your blood. So that's like 3 people right there. That's a lot of people in your physical space. And these are all people who are, again, on a time crunch. And so they're not asking first, they're just walking over to you and touching you because they assume that you agreed to all touch when you walk through the front door, which is not actually how consent works. Not cool. So that's a challenge. And then the multiple apps situation. So every provider, every healthcare system has a different app. Some of them are some of them are MyChart, some of them are Practice Fusion, some of them are this one, and then you have to manage all these passwords to get in on all of them in order to communicate. And some of them will send a message to your email when you get a reply, and some require you to check the individual portal repeatedly to see if you got a reply. Some people will send text message reminders. Some people will only do phone call reminders. But if you're like me and you screen all your phone calls because you hate talking on the phone, you won't receive those phone calls. So these are all like pretty common practices in healthcare that set people up to not succeed. All right, next slide. Okay, so healthcare provider frustration. So these are things, and I don't want to be an apologist for healthcare providers. There's a lot of ways that we could be doing better by our clients, especially our neurodiverse clients. I think there's a New York Times article that came out, I think today or yesterday, about primary care and how we have kind of a giant crisis right now in primary care in America. And primary care providers have the highest reported rate of moral injury out of all care providers in healthcare right now, and that people are fleeing the profession left, right, and forward in search of a better model, because it's actually painful to be a healthcare provider and know that you're not doing your best work, or that you're participating in an environment that's harmful to patients or doesn't meet their needs. And so for those of us who work already with, queer or trans or disabled or any kind of othered people, we already are aware of all the systemic injustice and violence that's done to our community and our patients. And then when you add all of the administrative stuff on top of that, it's like a death by 1,000 paper cuts. I'm preaching to the choir here because I know y'all know that this is a rough scene, but all of this is to say that I think most providers do want to do right by neurodivergent clients. They just don't know how, or they don't feel empowered to do it. And so these are some of the things that I hear from my own colleagues when they cover for me. And I happen to have a pretty large neurodivergent population because, as all of us know, the Venn diagram between gender diverse and neurodiverse leaves like a very big pile of humans in the middle, and those tend to be my humans. So when I have providers cover for me, these are things that they tell me is like the biggest struggle for them. We're trying to get a medical history in 5 minutes or less, but some patients, the more you rush them or try to extract information from them, the more they clam up or shut down. And so we're trying to help get the information out if the communicating part is hard, but in trying to help, we're making it worse, and it feels like the Spanish Inquisition. Different patients have different triggers, and so sometimes what you did that helped one patient, you try to do for this next patient, and it totally sets them off. Or they're like, why didn't you set it up differently? And you're like, I don't actually have that much control over anything in our environment, so it's really hard to personalize. We want to help patients when they're emotionally flooded. We can see it's happening. We can tell that they're struggling, but we haven't been trained at all. So I will tell you, in my nursing practice in the I've been practicing since 2008 as both a nurse and a nurse practitioner. I have never once had a single lecture on neurodiversity, not even an hour that was devoted in all of my medical training to specifically what that would look like. Not even in pediatrics was I given a whole hour on neurodiversity. I think I had a lecture that was 4 hours long, and that was on underserved populations, and that included the elderly, anybody who's unhoused, anybody with an addiction issue, anybody who's queer, LGBTQI, anybody neurodiverse. It was like everything that wasn't normie, and it was 4 hours, and that was maybe it. So most people haven't gotten a lot of training around this, and they don't have a working vocabulary for it, or a very clear understanding of it. As providers, we're really good at reading the room usually, and we monitor emotional cues on patients to see if what we're saying is landing, if they're hearing and understanding what we're saying, if the plan works for them. But when those emotional cues are muted or they show up in very different ways for neurodiverse clients, we can't tell if we're doing it right, and frequently we think it means we're doing it wrong. And so then we stop talking, or we clam up, or we start going faster, and it gets real awkward. So not having an understanding of how you know you're on the right track as a provider is hard. It's like giving a Zoom lecture and not being able to hear or see anybody on the other end. You're just kind of talking into the void. A lot of times patients and family members assume that the buck stops with the provider. And if the provider just said it was okay, everybody would be okay with it. It must be because the provider's not willing to say, no, you get to make special exceptions for this patient, that we can't meet their needs. And it's actually not the case. It wasn't until my 4th practice that I participated in that I had any control over my schedule. And in fact, most of the time people are empowered to put things on my schedule without communicating with me at all. So I could be in the middle of a visit with you, and then 10 minutes into that visit, somebody has been placed in an appointment time that started 5 minutes ago. Like it defies the time-space continuum, how we add patients onto a provider schedule. And I could ask and make a request of the front desk that they take a patient like immediately back to a room every time and don't put them in the waiting room. But the larger the organization, the less control providers actually have over any aspect of the care. So it feels particularly hard when somebody's like, why won't you help me? You're in charge. And you're like, I'm not actually in charge. That's not something I have control over. Okay. So shopping lists. So this is an idea. This is a set of ideas that that I would recommend that anybody have before going into a primary care space, but specifically clients with additional challenges. If they knew to ask some of these things ahead of time, that might help them narrow it down to make sure that they're even starting in the right place. Because I think there are a number of facilities that they would just kind of cross off their list immediately if they asked some of these questions and got the answer. It's another way for potentially healthcare providers and mental health care providers to talk about healthcare anxiety with patients, to say, like, you know, of the things on this list, which ones feel the most important to you? Which ones are the ones that you've personally had a traumatic experience with, that you like, that we can kind of highlight or tailor a search to? It's a good thing for caregivers to know about, that they could be asking ahead of time. This is information that's readily available. A lot of times, some of it's even available on the website for the practice, or it could be gotten from anybody who answers the phone with a fair degree of reliability. The only thing that they might not agree to tell you is this first question: how many patients does each provider manage on a panel? So a panel is what we call the number of patients that you're personally responsible for as a primary care provider. And I can tell you that when I worked for Neighbor Care Health, which is one of our largest community health organizations in Seattle, my panel was 1,200 patients that were personally assigned to me alone, which meant every lab, every time they went to the hospital, every refill request, every patient message went to me. Anytime they went to PT and somebody had to sign the PT note, that also went to me. So for 1,200 people, I was like the go-to person. When I moved to my second practice, which was a Peter Shallot, which was a private practice that still accepted insurance, my panel size was 950, and I thought I hit the jackpot. I was like, whoo, my quality of life is so good at 950. And then the pandemic happened. So when all of the other offices were closed or not accepting patients or couldn't take new referrals, I still had to see all the same 950 people, except I had to do it without specialists, right? And keep in mind that this is like people who need to go to me first before they can find you. So they need to find me so that they could get a referral to come find you. So obviously the number of patients assigned to each provider affects the quality of care that each of the patients receives. It also affects the ability of the provider to even track or remember who your patient is. And having a personal relationship and trust and rapport over time is the thing that is, the therapeutic value inherent in primary care. And so I do my best work when I know everybody well, and I remember that this person gets really squicked out by this thing, and this person does better if I present options first, and this person wants to know only the hard facts, but only at the very end. I can keep that all in my head successfully, but not for more than like 400 patients. So 1,200 is a real tough sell. Now, a lot of places won't want to tell you this because then it'll be clear to you what a shit show it is, to be frank. But if you can get them to cough up that data, it's important and helpful. Is there so more environmental control? You'll have a sense of how big a practice is and how chaotic it is just based on how many providers there are and how many patients per provider in the building. Is there a low distraction waiting room or an option to skip the waiting room at all? Is a great question to ask because that's a sign of some of the adaptability of the facility. And if they've ever been asked that question, then you know that they've probably seen some other neurodivergent folks before and paid attention to their feedback. Communication options. So in my current practice, which is direct primary care, the idea is that I don't bill insurance at all. So patients pay a fee per month and they come see me, and they can come as many times in that month as they want to for that same flat fee. And it doesn't cover labs or medications, but it does cover all communications. And so part of that is that we have a messaging app system. So it's basically like text messaging that has the option for FaceTiming, not through Apple products, a patient on a HIPAA compliant portal or phone calling them. So patients can come in person, they can chat me direct, they can switch to a video visit if they want, or if they really don't like having their video on and they just want to talk to me on the phone, we can do that through the app as well. So that's a really nice option because it gives people a lot of flexibility depending on their communication style. It also allows patients the ability to do agenda setting with me prior to a visit, which I find really helpful as a provider, and I think a lot of patients find useful too. So an example would be like, I have some patients with ADHD, and so remembering what it was that they even wanted to talk to me about when they get to the visit 3 weeks later is a struggle, right? And so what I encourage them to do is to drop bullet points into the text app as they think of them, because it's just chat and it's not going to wake me up in the middle of the night. So I'm like, if you're up at 1 and you're like, oh, I got to ask Jonathan this thing, I'm like, just drop it in the text app and just say for later, and then put your bullet point in there. I can review that text app before our next visit. I'll pull all of those out as agenda items, and then we'll talk about them when you get here. It works great. It's a really nice way to let people react in live time when their brain's focused on it and not have to try to pull it back together later. A lot of places that aren't like direct primary care, don't have that one-to-one access, do at least have portals. And with portals, you can send messages to providers. So people could send a message that says non-urgent medical question, and then say, this is a list of agenda items for our next visit, and then just drop it right there. So that's an option. It's also an option to ask for an appointment remotely versus on the phone. A thing I would like to call out that a lot of people don't know is that the appointments that are visible and available online are often not the sum total of what's actually available to a patient. So I know for every practice I've ever worked at, what we do is reserve extra spots for emergencies or urgent visits or that kind of thing. So there's always more appointments available than what you can see if you're using online scheduling. So if patients are frequently frustrated, they're like, man, I can only schedule 3 weeks in advance with my provider, but I have this thing on my leg that I think is infected. What do? I don't want to go to urgent care. That is one of those times that it's worth a phone call, even though phone calls are painful, because they often can get triaged into an earlier slot. It's just a question of like, how many spoons do I have? How many spoons does it need to make this phone call? Is it worth that number of spoons to me? If somebody knew that that would actually make an appointment possible for them, it might be worth it. It would change their calculus on the spoons, right? So it's something worth flagging. And then the last one, which I think is probably one of the most important things, is how do patients receive a summary of what actually happened at the end of the visit? It is now a law in Washington state, and I can't speak to other states, that all charts and all aspects of charts have to become visible to patients, meaning patients can see the provider end of the chart note and have to be able to visualize that through any portal system. So it is no longer the case that the only way to look at the note is whatever the provider summarized for you, which often doesn't say what the provider think happened in the visit. It doesn't reflect like the tenor of the conversation or the nuance of it. I do think it's quite revealing when you read other providers' notes, how they talked about a particular concern or how they viewed your level of distress and how they decided to chart that. It says a lot about how they're processing your interaction in live time. So that's another way to get a much better idea of what the provider thought the priority was at the end of that visit versus what you did. And being able to see a summary of those visits, like within 3 days of the visit, is important to figure out what the next steps are. There's something I call bad day flexibility with my patients, which is like if you have a bad pain day or a bad anxiety day, or everything about your transportation falls through at the last minute, what do we do to flex with that? And sometimes, most times, these are not things that you have a lot of control over in advance, and that's part of the nature of the disability, and that sucks. And trying to muscle through it is in fact going to be more harmful than successful in a lot of cases, and sets everybody up for a bad visit if you do finally make it there, but you've had such a bad day getting there that you're already completely done, shut down, and out of spoons. So finding a practice where they have the ability to flex with you in certain ways is really important. This switch from in-person to virtual is actually not a big ask. So from a practice perspective, I have a certain amount of time allotted for each patient. And if I ask them to come in person, it's usually because they need a blood draw or I do need to be able to do a physical exam for the thing that they requested. But for instance, you're like, I wanted to go and talk about my right knee pain, but I also wanted to talk about my anxiety medication. And then you wake up and you're like, I'm having a terrible day. I'm completely overwhelmed. I don't know how I'm going to make myself get on the bus for this visit. Could you write in and say, hey, I'm not going to be able to talk about the right knee today, but I still do need to talk about my anxiety medicine. In fact, my anxiety is rotten today. Can we switch to a virtual visit? The virtual visit is actually quicker and easier for me to complete from a documentation standpoint as a provider than an in-person visit. And so the last minute switch to virtual doesn't take anything out of my day. And it doesn't affect the way that scheduling happens meaningfully. In fact, it probably would increase a little bit of the amount of flexibility in my schedule and time. So asking if that's an appropriate request, and if it is, who to contact day of to make that request for the future is a really key one. All right. And this is setting people up for success. And this is stuff that I'm not y'all, I don't do what you do, so I don't know if this is an appropriate request, but I know some of the therapists that I've worked with collaboratively with patients will say, hey, we've been working up to getting over the hurdle of this one appointment for quite some time. And so we want to do some skill building or some expectation setting or anticipatory guidance with this client regarding a medical appointment. What are some things that we can do? These are things that can increase the efficiency of the visit and get through the interrogation part a lot quicker, and helps the provider kind of digest a bunch of information in a short amount of time, so that we could be like, okay, now that I have that going into this, it's going to change how I approach this visit. Things that would really be useful. Having a list of triggers or fears in healthcare spaces. So if a client already knows going in that the worst part for them is a blood draw, if I know that up front, I'm not just going to be like, oh, and then we'll do a blood draw, blah, 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 blah. Because then the person's like, ah, you're gonna sneak attack me at the end of this visit. I feel it coming. So if I already saw that on the list, I could be like, hey, I saw that you mentioned that this is a thing. It does not have to happen today. It's something we could schedule in the future and prepare around. Perhaps we could pre-medicate. Perhaps we can set it up at the end of the day so you have a lot of time to take deep breaths and you're not going to be worried about other people's appointments behind you. I won't just like sneak attack people with the idea of a blood draw if I knew up front that that was a big thing to keep an eye out for. Similarly, if somebody's like, touching my neck is like a whole thing and it can't just happen. As a part of a routine, head to toe exam, we would at some point come towards somebody's neck. If I knew that ahead of time, I would say, hey, I would like to do a physical exam. Today I was hoping to be able to check these parts of your body out. Is there one of those you want me to skip today? We would have that conversation ahead of time so somebody felt like they knew what was coming before it happened. For me, I know I would really, really love a list of strategies or suggestions for when people are flooded. Sometimes the way that we ask somebody if they need help is triggering in and of itself for folks. So I could be like, you look like you're struggling. Do you need help? And they're like, yeah, and I also need $1 million, but like, that's a not helpful question. It's way too much for where I'm at right now. Versus I have a client that I'm thinking of right now who asked me to ask, do we need a video break? And a video break is their cue to pull out their phone and they watch a cat video, and it feels a lot more calming for them. And it's like 30 seconds. And I know why they've pulled out their phone and why they're watching a video. And we all just take a pause. And then at the end of the video, they engage when they're ready. And that feels less patronizing to them than when I'm like, are you okay? But it also cues them to use a skill that they already have that they know works for them. So if I knew what some of those cues were going into a visit and I saw that something was happening, I could use one of those and I would feel less adrift as a provider in that visit. And then I can't emphasize enough the importance of a healthcare advocate. Having somebody else in the room who can validate that that visit went the way that you thought it did, or it was what it was, or even to remind you like, actually they said this thing, or they said that they would contact us in this way, is so helpful. And from the provider end of things, I know some providers tend to feel that that's adversarial. Anybody who thinks that's adversarial is probably the wrong provider for you to begin with. But specifically, if it's a repeat person who's the healthcare advocate, it becomes like part of the communication environment. And I'll say to clients like, hey, on hard days or whatever, would you rather that I ask Opal about scheduling rather than you, so that it's not something that goes into your brain space and your to-do pile? Or I will say to a patient, hey, can I ask Opal to reflect back what they've seen has changed since you started this medication, after I asked them what they had thought had changed, because it helps to get something mirrored back and outside experiences. So it is challenging when it's a different healthcare advocate each time. That dynamic gets kind of confusing. And so I've had some patients who had like a different partner every time. And I'm like, hey, I'm totally cool with you having supportive partners. But when it's a different person every time, a lot of times they don't know me or they don't know what happened at the last visit. And so then the advocate's asking questions about what just happened in the last visit. And that can be distracting or take away from the time in the visit. Healthcare advocates are not a paid for, not an insurance covered service right now in the United States, which is a real fucking bummer. It is something that you can hire professionals to be your healthcare advocate, but it's cash pay and it's pretty pricey. It's usually about $125 an hour when I've done the research on that. If you have a really good healthcare, so like a good caregiver, so like in Washington State, we have a program called COPES where people who are your family members or your roommates who already live with you can get paid part-time for their work as your full-time caregiver. So if you have a situation like that where it's somebody who knows you really well, or you're in a adult family home and it's somebody who's worked with you for years, or you have a case manager, for example, those can be really good ways to get that kind of support, or a parent in some cases. Yeah. It's never a good sign when the provider only talks to the advocate and doesn't talk to the patient. That's always that's a red flag all the way around. So if you ever have someone come back to you and say, oh, that they wouldn't talk to me, they just kept talking to the other person in the room. If they only want to talk to the person they perceive as the normal person, that's a no-go. That's not going to get better the longer you are with that provider. So that's my TED Talk. I would love to take questions at this point.
Wonderful. Thank you so much. We have a few questions. I'll go in the order that we received them. The first person was Kate Shelton. They have to go soon. So go ahead, Kate.
Kate, you're on mute.
Hi.
Oh, there you go.
Hi. My question for the group is actually for the consult period. So if we don't get to me by the time that we go, that's fine. But if it's questions on the presentation, then those should go first.
Okay. Thank you. The next question is, so can people request extended time with their provider ahead of time as an accommodation?
That's a great question. You could always try. Typically, the way that it works is that the organization sets a set amount of time per type of visit. So for example, an annual exam or an annual healthcare review visit will get 30 minutes every time. Anything that has to do with removing birth control, even though removing an IUD takes 15 seconds, you'll get 30 minutes for every single time. But so shockingly, you only get 15 minutes to talk about mental health. So you can always make the request, hey, because of our documented disability status, can we request that all appointments start at 30 minutes? That's totally a request you can make. I don't know if it'll be honored, but that's the request option.
Great, thank you. The next question is, can patients make corrections to info that was misconstrued and recorded in their charts incorrectly?
Yes, and it's tricky. So one of the things that happens is that each charting software that a provider uses will auto-populate out the name of the diagnosis based on what they have in their system. For example, so gender care is a really good example of this. If I put transgender as a diagnosis code, sometimes it populates out to gender identity disorder of adolescents and adults, which is gross. Or sometimes it auto-populates out to transsexualism, also gross. So I have taken with the current software that I have to documenting gender dysphoria as the condition because it's the only one that's somewhat accurate that doesn't offend anybody. So a lot of times when that looks like it appears incorrectly or misconstrues, it's not necessarily because the provider even thinks that's the right title. What the provider typed in and what auto-populated are two different things. One thing that you can do is send a message to the provider and say, hey, it says on here that I have a bipolar diagnosis, but I don't. I've never been diagnosed with bipolar disorder. I've been diagnosed with a mood disorder, but I wasn't told which one. That is a correction that you could make. It's trickier when there's a disagreement in the medical chart. So sometimes the diagnosis that a patient will see listed on their chart is because it came in through a different source. So if it was documented anywhere in the ER at the University of Washington, it auto-populates out into their medical record as a primary care patient. And so if someone at the ER said this, it's now officially part of the record in primary care because it was input by a provider who was moving a mile a minute. So to make those medical requests, the primary care provider of record for that patient can address that and update it, but it doesn't entirely remove it from the chart. It'll be listed as a past condition that has been resolved, but it won't ever remove it entirely from the chart.
Thank you. And then there's two more questions. One of them is currently going on in the chat. Bobby Joe asked, does anyone have or know of a template that exists already that includes some of these things? Bobby Joe, do you mind expanding on what you mean by some of these?
Just checking kind of with the whole group to see if anybody had known if there's like a pre-existing form that like somebody like, or that I could sit down with a client and help them talk through so that they could walk into their new doctor and provide this. I know my most of my clients that and some of the folks I'm thinking of have like really long health histories. And so if it is not extremely clear of where did they start, where did they stop, the idea of kind of free forming and just writing their needs is not specific enough for them. And so I just thought if there's something existing, I like to create those kind of things, but my content creation list is getting really long in the back of my mind. So I just thought I would check if it does exist. If not, I'll add it to my list and work on it and be happy to share with everybody else. But I think it would be a super helpful tool. And I have one particular client that I think could really benefit, and we've sort of talked about it, but I really appreciated having some of those things from a provider's perspective of what is it that you actually want to know? Because I also don't know exactly where the start and stop line is, right?
Yeah, it's pretty discreet. Like, like, did you have a surgery? What year? Who's your endocrinologist? Who's your physical therapist? Who's your psychiatrist? Just like having their names and what they do for you is like a huge help, having that all in one place, because that's a document I can hand off to my medical assistant to put in the chart later. So I'm a very expensive typist. So if I'm sitting there like trying to write this down as you're spitting it out and spelling it wrong, it's going to make the like release of information and the records request go really stupidly. So like if we could just like photocopy that and stick it in the chart, that's going to go way better for everybody.
Yeah, and I know with some folks that I work with that do have complex stuff because of how their neurodivergent brains work. Like if you ask them, like I have one client in particular, if I ask them one question, it's a minimum of 10 to 15 minutes of a response for each question, because they can't, like, this is connected to this, is connected to this, especially autistic and ADHD put together, right? And so for them in particular, they have that dynamic where they end up, what I'm gathering is they end up overwhelming all their providers, who then kind of shut them down. That triggers all their, trauma and dismissal stuff. And so it's just like this ongoing dynamic. So we've really been trying to work on brainstorming different ways. And so I do think that because they have a need to continually meet with new providers, figuring out some stuff, I do think something like this might be helpful. Because yeah, stuff just keeps getting missed because providers don't ask enough questions to get history. And then at the same time, I also think I really liked that idea about what are the specific triggers kind of thing would be really helpful for them to name. And if I could help them with it, we can maybe pare it down so it's readable. That's the other thing, right? If I ask them to create this, they just had a psychological assessment, and literally there was one question that I think they submitted 15 pages, right? For one
I've got
question
some paper
answer.
with like answers written around the margin and then wrapping around the back, and then there was like a diagram, you know, like and
which my mind says, because they're getting an autism assessment, and my mind says, shouldn't that like be
yeah, I know,
like,
right? An assessment tool.
I as the provider would interpret that as just further evidence, right? Like neurotypical people are not likely to give you a 15-page summary of what is your trauma history or something like that is the question, right? So yeah, thank you.
Absolutely.
This was so helpful to me to understand more from your perspective as a provider, so I know how to better prepare my clients for going to appointments. This is a conversation I have a lot with clients, and then also to know what is actually helpful to you, because that slide was so helpful because I wasn't really sure what information do you need ahead of time. And I know the reality is I can't just call every provider. You don't have time for that.
Right. Well, and you don't have time for that, frankly, you know, like it goes both ways.
Right.
And I think when I get handed documents like that, I'm always like, hey, this was so helpful. You know, anytime you want to bring a document in advance of a visit or send me updates in advance of a visit, like I welcome that as a provider, because that's all stuff that I can drop in the HPI like before I even get into the visit, and that helps me be specific. So like if somebody sent me a list of updates on their IBS, right, and I get into the visit with them, and they're kind of scattered and having an all over the place day, I'm like, okay, so in your updates, I noticed that you said this felt better, but this felt worse. Can you tell me more? And then we can like drop in on the thing at hand. Or if somebody's like, goal for today, and they had 16, which legit has happened, I'll be like, okay, how about we do one of yours and one of mine? So like there's always a goal that I have for a visit that's separate from a goal that a client has for a visit. And that's just the way it goes, because I'm in charge of keeping them alive like longitudinally, you know, and I have all the cancer screening and all the unfun, like kicking the tires, rotating, you know, the tires kind of stuff that I have to do. So usually what I'll say to patients is I'll just acknowledge it up front. I'll be like, there's stuff that I need to do that is not on your priority list. So like, why don't we do one of your big priorities and one of mine today? So that way, like everybody's getting the stuff that they need out of the way.
And then I had one more question. So all of this felt so helpful and supportive. If somebody is able to find a provider they can access who does have the awareness that you have, do you have advice or suggestions for how we can support our clients who just need to work with a provider they're connected to and it may not be the best fit?
Yeah, so I think one thing that helps is those bulleted lists or agendas at the beginning of every visit. So if communication's a thing and a client knows that getting there, they're going to feel overwhelmed and kind of shut down and have a hard time saying things, if they handed off the list of like things that I've been most worried about. Another thing that is helpful is if they say like, you know, 0 to 10 level of worry about the symptom that I'm having right now, right? So that even if a provider has a hard time communicating with them, they can at least see what is the impact of this symptom on this person, right? Sometimes it's the case that somebody is like completely distressed about mucus, and I'm like, it's a cold, it's nothing, and I want to blow it off. But for whatever reason, whether it's their OCD or I don't know, like the mucus is the thing that's like causing serious distress, we're going to end up in conflict in that visit because I keep being like, why do you care about the mucus? So like if I had a bullet point at the top of the visit that's like things that are happening in my body and my level of distress associated with it, that would be really helpful for me. Yeah, because even if you're not a particularly emotionally aware person, you'll at least know what's a hot button object and what's not.
That's super helpful. Thank you so much for sharing with us. It's
Yeah.
really good to hear from a medical perspective.
And, you know, I definitely think we can do better in medicine. Consent is like a consent language, and medicine is like a particular deficit. It's something I work with my residents on, and nurse practitioner students, because I think we forget that you really do have to check every single time for every single person. I have patients I've taken care of for 10 years, and I still ask every time before I put my hand on their back. because the more times you do it, the more times people trust you. So consent language, really important, something we could learn from y'all. And anytime you want to collaborate, I think you would be surprised how often primary care really appreciates hearing from you guys as clinicians, especially if something's gone wrong or somebody's like losing sleep over it. I think there are a lot more primary care that would want to know and would reach out if they knew how distressing a thing was, and they just have a hard time getting that information in live time or that feedback.
Thank you. This is really
Yeah.
helpful. We are about to move over into consult time. You're welcome to hang out with us if you want to. I appreciate you being here so much.
Yeah, it was really great to work with y'all, and thank you for all the good work you do for our people.
You too.
See you soon. Bye.
All right. Bye.